Welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database Monthly webinar. Today is Tuesday, June the 17th. So thank you everyone for joining today. On the call with me today from the STS side, we have myself and Emily Conrad, Banu Yatsi. We have Nancy Honeycutt, Paul Meehan, and then we have our consultants. We have our CHSD consultants, Chastity and Leslie. Our ACSD consultant, Melinda, is joining us today. And then we have Dr. Jacobs from our surgeon leadership side joining today. So again, thanks for everyone for being on. Typical agenda, I'm going to provide a couple of brief STS updates, and then I'll turn things over to Chastity and Leslie for our STS data manager education. And then as usual, we'll finish things up with our Q&A. So please be sure to submit your questions via the Q&A function. We do have the raised hand function enabled. So just ensure that your microphone is enabled on your end. So welcome to raise your hand to just ask your question as well. So let's go ahead and get started for our STS updates. As you may or may not be aware, the June training manual was posted and is available for your access and download. Again, just go ahead. That June training manual is now available to you. The 2025 harvest schedule, the spring 2025 data analysis was completed, and the reports were released to database participants on June the 2nd. And that official communication, again, was sent to all database participants. The fall 25 harvest close is scheduled for September the 26th, and the opt-out is scheduled for September the 30th. Quick STS update. For those, after the reports were released, we got a couple of questions regarding some numbers being reported in extubated in OR and reintubated for respiratory failure. And we did, after some review, we found out that for those two components in tables 18 and 19, again, extubated in OR and reintubated for respiratory failure, the calculation was not taking into account for 623 cases. So we have updated the calculation for tables in 19, again, specifically for extubated in the OR and reintubated for respiratory failure for both the participant and the STS overall. We have updated those calculations to include the version 6.23 cases, and I have two slides that I'll show you specifically what's being updated. These updates will be included in the July 12 IQVIA report release. So again, these have not been implemented as of yet. IQVIA is currently working on these updates. So again, specifically for table 18, the updated calculation you'll see the updates are in red. So for right now, currently the calculation only includes intubate equals 1, which is intubate equals yes. That's version 341. In version 623, we broke it out a little bit further. So in version 623, it has intubated yes. I think it's yes in the OR or yes prior to entering the OR. So unfortunately, the calculation was not taking into consideration yes prior to entering the OR and yes intubated in the OR. So again, the calculations have been updated to reflect that accordingly. And again, here's the updates for table 19, very similar. We're taking into account that intubate for 623, intubated yes in the OR or yes prior to entering the OR. So those are the updated calculations. The current spreadsheet, calculation spreadsheet currently posted in the IQVIA platform has not been updated, but when these calculations are updated and revised and posted in the IQVIA platform, we'll post a notification and also alerting you to when the new calculation spreadsheet is available for you as well. AQO 2025, just a reminder, the CHSD and GTSD sessions will be held on Thursday, September the 25th. The ACSD session is scheduled for Friday, September 26th. Intermax and PDMax session will be virtual. It's going to be Tuesday, September the 23rd. Again, the Intermax and PDMax session is a virtual session. We do not have in person for Intermax and PDMax. We'll be at the Grand Hyatt, and again, we do have the virtual and in-person options available for ACSD, CHSD, and GTSD. Emily, did you have anything you wanted to add regarding AQO?
We'll have an agenda on the STS website shortly. I'll be getting that over to our marketing team this week. So we'll
Mhm.
put that on our website. Abstract submission closed. We had 20 abstracts that were submitted this year and are in review. The program's looking great. We're excited, for our presenters. It's looking really good for CHSD. So we're excited to share that information on the website shortly. And for yeah, I think that's about it to clarify for the moment. So
Yep.
thanks.
And AQO registration is now open. So here's the link to go out and register for AQO. If you have any questions, just let us know. Just also just a little heads up for AQO. We're going to be offering a little, I guess you can kind of say like a little drop in our CHSD consultant chat prior to the start of AQO. More details about that coming soon. That'll be just kind of a very informal drop in. Chas, Leslie, myself will be hanging out at registration the night before. So just, just an informal drop in, come chat with us, and we're happy to answer any questions. But again, more info about that coming soon. But yeah, we look forward to seeing you all at AQO, and hopefully we can see you in person. If not, we'll see you virtually as well. So we just look forward to it and hope you guys are able to come see us in San Antonio.
There's
Uh,
there's two
yeah.
questions about the fall harvest coinciding with AQO. Um,
Mhm. Let's
eh,
see here. Does the fall say yes? So the fall CHS harvest close coincides with this year's AQO. Has it been decided not to change the fall harvest close? So yeah, so Carol, we've been talking about this, and actually so we have a few options that I wanted to present to you all to set kind of see. I don't know if we could do a poll really quick, Carol, or would you just rather do like a thumbs up, thumbs down? I don't know if you're able to unmute, but so we were looking at dates. So obviously we moved the date up for AQO to the 25th and 26th because of Yom Kippur falling the week after. So we would not want to obviously have a harvest close during a major holiday as well. So our options are we could move move the harvest close date up a week. So we could do that, or if we delayed harvest close to, let's say October, I'm sorry, get my calendar out. October, the week after Yom Kippur. So October, sorry, I don't have my calendar out. Like October the 10th. We could also do that as well. Obviously, we still need to discuss these options with surgeon leadership, but the longer we delay it into the mid of October, it'll be, December before we get reports out. So those are the two options that, we have. We could move it up a week, or we could push it back to after to that second week of October. So those are our two options. If you would like to move it up a week, give me a thumbs up, or if you'd like to move it back a week, whichever you prefer, you could show a heart. Just let me know, or just email me with your thoughts.
Hey, Leanne, can you hear me now?
Yes, ma'am, I can hear you now.
Woohoo! Yeah, I just moving the harvest. If you could just get your data in early before the harvest close, I think that that's a better option than moving the harvest date. Um, the harvest, if you're, I think that how many weeks did we say it was like 12 weeks after the
Yeah,
last day of conclusion?
yeah, it's 12.
Um, And we really don't want to defer it any longer, because if we have to defer it, you won't get those reports back until likely December. We have the morbidity going in, the new morbidity going into these reports.
Yeah, it's
So let's see. We can do a poll. I can put a poll and hold.
okay. Yeah. So. But yeah, we can come back to the poll, Carol, and after
Yeah,
Chastity
let me
and
put
Leslie.
it in real fast, and then we can come back to it.
Okay, yeah. So while we're getting that, so again, just think about that, and then we'll do the poll here at the end of the session here. And so in the meantime, let's go ahead and turn things over to Chastity and Leslie, and they can get their education in, because they have a lot of info to cover. So let's go ahead and turn things over to Chastity and Leslie, and then we'll come back to that poll.
Thanks, Leanne. Hi, everyone. This is Leslie Wacker. Today we're going to review just kind of high level some changes to analysis that went in with spring 25. So we wanted to review those in the analysis overview. Do a quick review of the risk model, specifically in preoperative factors. We have a couple reminders about the training manual, and then we have some FAQ clarifications that came in through kind of May, June. So that includes COVID fields, heart failure for acute heart failure timing, and then shunt reoperation. Next slide. Next slide, sorry. A lot of title screens. So the first thing that we wanted to point out was in the analysis overview. We did add just to the cover page the spring 2025 analysis. So this will be going forward on the front page, just tell you which analysis period this refers to. So this one is for spring 2025. Next slide. And then as a reminder, when you pull that up, the date sort of embedded in the title of the document is just when we revised it or sent it over for publication. So we really, really try not to make changes to this in between analysis periods unless there's something glaringly obvious that we need to update. But that date that's embedded, we used to just tell you to refer to that for the analysis period. That then, so this one is May 30th, that just refers to when we finished the document, saved it, and sent it over for publication. Next slide. So two changes that we want to review. One is for identifying episodes of care, and this is what we refer to as two overlapping episodes of care. As a quick reminder, we have not changed the definition of an episode of care. That remains date of admission through database discharge date. That is the same. Calling it two overlapping episodes of care, I realize now, has caused a little bit of confusion because your episodes of care are really separate. They don't overlap. But how we're defining this for analysis purposes is when you have two index operations which occur within 30 days of one another. Again, we have not changed the definition of index operation. You still have two index operation, meaning two first cardiac operations of your episodes of care, but they overlap for analysis when those two index operation dates occur within 30 days of one another. And in that case, we're going to analyze the first index operation. The second one will be ignored. This is true of mortalities or survivals. And the change there is that it used to be the second, the one closest to the mortality date, if it applies. And now it is the first. And we went into much more detail about why and how this affects things in a previous webinar. I forgot to look up the date of that webinar. I believe it was January or February of this year. I will try to look that up. But we did go into a lot more kind of detail about how that works, why that was done, etc. Next slide. And then, of course, as we're all aware, the other big change to this analytical period was the way that we code primary procedure. So going forward, we have changed how we look at primary procedure, how we're coding right now in real time moving forward. That is all in the training manual. But those changes were also applied to the analysis period going back 4 years. So that is also listed in the analysis overview. It starts on page 4, continues on to page 5. All of the details, those different columns that we talk about, are in the training manual. Again, we did go over this, I believe, prior to the first of the year in another webinar. Next slide. This is a proposal that we would like to add to the analysis overview in the future, but we wanted to add a little bit more information for data managers just to kind of keep track of these changes over time. So the first part that you see at the top is just the version number with the go live date. So version 3.0 went live January 1st of 2010. So your surgeries that occur January 1st, 2010 and after were version 3.0 until we got to version 3.22, which started January 1st of 2014. And that will, obviously, as we progress, we would add line items to that. But this was just to kind of give a little bit better visual of when those things happen. And then the second part is for analysis updates. So just, again, not a ton of detail, but just a little bit of a at a glance what happened and what it impacts. So for our STAT 2020 update, that did change stat mortality scores and sometimes categories. That was first analyzed with the spring 22 report, and it included surgery dates from 2018 through 2021. And then the next two are this most recent analytical period, spring 25, including surgery dates 21 through 2024. Our idea is to maybe make these things in parentheses, like where it says Appendix C or page 3, make those hyperlinks so that you can get to more detail. But again, this is a draft. We'd like to include this in the future in the analysis overview just to kind of help keep track of some of these changes. Next slide. Next slide again. Sorry, I have so many title slides. Okay, just a little review on the risk model. We've gotten some questions lately about what is included. So specifically for this webinar, we're just going to briefly go over the preoperative factors. Next slide. But we wanted to point out that the current risk model is based on the 2019 update of the risk model. And that update in 2019, adjusted for the same factors as 2014, except adding more detail in NCAAs, chromosomes, and syndromes. It did not include updates to preoperative risk factors. Those are still the same from 2014. Next slide. So what that means is, in our risk model, the things that are adjusted for include preoperative VAD or ECMO, shock persistent, invasive mechanical ventilation, renal failure or renal dysfunction, preoperative neurological deficit. Next slide. And wanted to point out that this also includes code 440, stroke, CVA, or intracranial hemorrhage greater than grade 2 within 48 hours of surgery. Next slide. And any other preoperative factor except other preoperative factor, which is code 777. Next slide. Okay, so again, because that is from 2014, the other preoperative factors that are included are the ones that existed at that time. Next slide. So I won't read through this, but I just wanted to provide, we wanted to provide one cohesive list of what existed in that version and what is currently accounted for in the risk model. So these are all of the others, not including 777, that go into the risk model. So all, of course, those first lists that we talked about, and then any of these as other are included. Next slide. Okay, quick reminders about the training manual. Next slide. The training manual is based on the version. So this one is just a quick screenshot of the front of 623. Next slide. And this one is 341. Next slide. And what's important to remember here is that the training manual corresponds with your surgical event date, so your surgery date. So it is possible that you have a patient who was admitted and had a procedure prior to going live with 623 and has another procedure after going live with 623. And those two events will be abstracted based on the definitions and the training manual corresponding to that surgery date. We can't go back to old training manuals for definitions or clarifications if you just like it better for whatever reason, and we can't use new definitions and clarifications on older cases. Next slide. Okay, and then some clarifications from recent FAQs. Next slide. So first, regarding COVID fields, we are going to continue to collect COVID information, but now on the index operation only. You can continue to capture that on every event if you like. If your hospital wants to look at that, perfect. But right now we've gotten the okay to just collect that on index operations. Again, you don't need to go backwards and change anything. Just going forward, you're allowed to just collect it on the index operation only. Next slide. Heart failure. We've gotten a ton of questions about heart failure. The overall heart failure preoperative risk factor has not changed. The time frame remains any time between birth and OR entry. But we do want to provide some clarifications on the timing of acute heart failure. So again, just checking the yes, they have had heart failure in their lifetime. That's still collected the exact same way. Say yes, they've had heart failure sometime between birth and OR entry date and time. Next slide. But for heart failure timing, specifically for acute heart failure timing, and this will also impact if it's both acute and chronic. Next slide. This is what has been added. In order to code acute heart failure, the patient must meet both of the following criteria: a current clinical diagnosis of acute heart failure documented in the medical record during this episode of care prior to OR entry date and time, and the patient must be taking at least one medication other than diuretics alone or digoxin alone, specifically to address heart failure within the 48-hour period prior to OR entry date and time. Again, don't go backwards, just moving forward when you're looking at checking timing. They must meet this criteria to say acute. Next slide. Okay, I'm going to turn it over to Chess to go through some case scenarios.
Thank you, Leslie, for that overview. So we're not going to do formal polling, but I'm going to give you a few seconds before we advance the slide so that you can come up with your answer, and then we will discuss why your answer is correct, or it should just be correct. All right, scenario one, preoperative or prep factor heart failure. So you have a patient who is at home receiving Lasix, who is admitted for documented acute exacerbation of chronic heart failure. Their Lasix dose is increased and the planned surgery date is moved up by 6 weeks. Does the patient meet the criteria to select pre-op factor 670 heart failure? And your choices are yes or no. So we'll give you a few seconds.
Just let me know when you want to advance, Chess.
I'm going to say go ahead. So the answer here is yes, and this definition was also just explained by Leslie, but you can see in the definition in the current training manual for this version, it says code this factor if the patient has a documented history of heart failure prior to entering to OR entry date and time. So the answer is yes. Next slide. So again, this is the same scenario, but the question here is, what is the correct answer for sequence number 765, heart failure timing? Is it acute, chronic, both, or none of the above? Leave this answer blank. Okay, go ahead, Leanne. So the correct answer here is chronic. And Leanne, if you advance the slides, we can go through the definition. So this will be coming out in the July training manual that to a code acute heart failure, both criteria must be met. A current clinical diagnosis of acute heart failure documented in the medical record during this episode of care or prior to OR entry date and time. And actually this came out in June. We've added the word acute heart failure to the July training manual. And also, in addition to having a current clinical diagnosis, one must also meet the second criterion, which is that the patient is taking at least one medication other than diuretics alone or digoxin alone, specifically to address heart failure that would not have otherwise been used in this patient within the 48 hours prior to OR entry date and time. So we're really looking for acute heart failure to identify a patient population that truly is meeting this more stringent criteria. Chronic heart failure has a different definition, of course, and this develops gradually over time with symptoms of shortness of breath, lower extremity swelling, and fatigue, which of course you may see more in an adult patient without an acute exacerbation within the 2 weeks prior to admission. So we know that this patient has a history of chronic heart failure. However, they do not meet the criteria for acute heart failure, and therefore they don't meet the criteria for both acute and chronic heart failure, because while they have a documented definition of acute heart failure, they're on a diuretic alone and no other medication within that 48-hour time period of entering the OR. So we can only select chronic heart failure for this patient. Next slide.
Sorry, Chas, I didn't mean to switch.
No, it was
so
a
quickly. I was like, oh my
transition.
God, you didn't even get a breath. Sorry
Nope.
about that.
You were great. I just came back from Chicago, the Windy City. I'm good.
Okay, sorry about that.
You're fine. Okay, a second scenario for the pre-op factor heart failure. A newborn transferred to the surgical center on day of life 0, arrived intubated with epinephrine and milrinone infusions with a documented diagnosis of cardiac dysfunction, as well as acute systolic and diastolic heart failure. Following immediate bedside balloon atrial septostomy, the inotropes were discontinued. Diuretic therapy is initiated and continued, and then on day of life 9, the patient goes to the OR for palliation. What is the correct answer for sequence number 765, heart failure timing? Is it acute, chronic, both acute and chronic, or none of the above, leave blank? Okay, Leanne. So the answer here is none of the above, leave blank. So as you know, this patient is only 9 days old, so they don't have a diagnosis of chronic heart failure yet. And while they carry the diagnosis of acute systolic and diastolic heart failure at the time or within the 48-hour time period of the patient entering the OR, the patient was on diuretic therapy only and no other medications for heart failure. So in this instance, we would have to leave this timing blank. Next slide. And this should just, again, explain what I just said. To meet acute heart failure, you have the clinical diagnosis of acute heart failure in addition to taking more than a diuretic alone in the 48-hour time period prior to entering the OR. Next slide. And then this should just be the definition of chronic heart failure. And again, this patient doesn't meet criteria for acute or chronic heart failure in this scenario. So I know this is a change that started last month with the definitions, with our update or clarification to the definition of acute heart failure. But remember, as Leslie just pointed out in our discussion regarding what is being analyzed as a part of our risk model or adjusted for in our risk model, heart failure hasn't yet been added. So it is not one of the pre-op factors that's included. So we're not going to ask you to go backwards at all. From this point forward, you're going to apply the new definition and criteria for heart failure. Next slide.
Sorry, it's me again. Clarification to shunt reoperation. So this previously said revision or replacement of a previously created shunt. This has been updated to not include replacement. So in the event down here at the bottom, it says in the event an existing shunt is taken down and replaced with a new shunt, code the specific type of shunt placed, as well as procedure 1630 shunt ligation and takedown. And then Chas will join in with some case scenario.
So let's go through some examples, and most of these come from you guys that submitted FAQs. So here is our first scenario. A patient with an existing modified blade lactosic shunt is admitted with shunt failure. They're taken to the OR for placement of a new modified BT shunt with the removal of the existing shunt. What is the correct primary procedure? Is it 2095 shunt reoperation? Is it 1630 shunt ligation and takedown? Or 1590 shunt systemic to pulmonary modified blade lactosic shunt? I'll give you a few seconds. Okay, Leanne. So the correct answer is 1590 shunt systemic to pulmonary modified blade lactosic shunt. And next slide, we'll have some explanation. So remember, Leslie just presented the same slide that in the event an existing shunt is taken down and replaced with a new shunt, code the specific type of shunt placed. And in this scenario, that is our modified BT shunt, and then procedure 1630 shunt ligation and takedown as a secondary procedure. And this was an update made in May of this year. Next slide. All right, so following scenario. A few days following the placement of a sono shunt, the patient requires banding of the sono shunt due to excess pulmonary blood flow. What is the correct primary procedure? Is it 2095 shunt reoperation, 3680 RV to PA shunt, or 2010 cardiac procedure other? I'll give you a few seconds to think this through. Okay, next slide. So the correct answer here is procedure 2095 shunt reoperation. And we'll go to the next slide for some explanation. So when we look under the procedure for the sono shunt or 3680 RV to PA shunt, you will see that an update was made that says in the event and the RV to PA shunt is banded during the same operation, you're going to code this banding of the shunt as procedure 2010 cardiac procedure other. In the event the shunt is banded during a subsequent or separate operation, as in this scenario, you're going to code procedure 2095 shunt reoperation. Next slide. So scenario 5 under shunt operations. Following placement of a sono shunt, the post-op TEE in the OR reveals excess pulmonary blood flow. The patient goes back on bypass and the sono shunt was then banded. What is the correct way to code the banding of the shunt? Is it 2095 shunt reoperation, 3680 RV to PA shunt, 2010 cardiac procedure other? And we'll give you a few seconds to think this through. Okay, Leanne. So here, because the procedure occurred, the banding of the sono shunt occurred during the same operative event or in the same OR setting, you're going to code procedure 2010 cardiac procedure other. And if we move to the next slide, you'll see the same clarification that in the event the shunt is banded during the same operation, code the banding of the shunt as procedure 2010 cardiac procedure other. And only would you do shunt operation if it's banded during a subsequent or separate operation. Next slide. And this is just a last scenario based on some questions that have come into the box. It doesn't have anything yet to do with what Leslie has presented, but this seems like a good place to throw this in. So the patient decompensates in the OR following an arterial switch operation. They are transferred to the cath lab where imaging reveals a kinked coronary artery. They're transferred back to the OR for coronary artery repair. How is this event best captured? Is it A, enter the coronary artery repair as part of the arterial switch operation as the patient has not returned to the CVICU yet? Or is it B, enter the coronary artery repair as a second or separate operation? Or is it C, include the cath lab imaging as an unplanned interventional cardiac catheterization procedure? Give you a few seconds to think this one through. Okay, Leanne. So the correct answer here is B, enter the coronary artery repair as a second or separate operation. And next slide, we'll go through why the other answers are incorrect in this scenario. So enter the coronary artery repair as a part of the switch as the patient did not yet return to the ICU. No, a cardiac case ends when the patient leaves the OR. And then include the cath lab imaging as an unplanned interventional cardiac cath. This cath was diagnostic only where it just said imaging revealed and no procedure was described. So we would not include this as an interventional cardiac cath in your post-op event section. So next slide. You will see that we spell this out in the training manual under clarifications for the time patient exited the OR. We said the time the patient physically leaves the OR or surgical location is the end of the case or the procedure. And this was an update made this month in June. And you'll see that in the training manual as well as the companion document listing a list of all changes made to the training manual since its outset. Next slide. Another reoperation scenario, the patient decompensates in the OR following an arterial switch operation, transferred to the cath lab where imaging revealed the kinked coronary artery. They come back to the OR again for repair of the coronary artery. Is this considered now an unplanned cardiac reoperation? Yes or no? Okay, Leanne? And the answer here is yes. The initial case has ended. The patient has left the OR and you've returned now to the OR. Nowhere did we think we were going to be repairing the coronary artery. It was not known prior to going for the initial arterial switch. And so not planned during the initial surgical planning. So everything about this is an unplanned cardiac reoperation. Next slide. So in summary, we want to always make sure that you have your training manual open at all times. Again, you can't remember things from version 3.4.1 as many definitions have updated, many procedures and how to code certain scenarios have been updated in the training manual. So you really want to have it open at all times and looking up all of the fields that you are coding. Pay attention to the monthly updates as well as the companion document, which does make it easier to see what has updated month to month. And when in doubt, please submit a clinical question. We are very happy to answer your questions. And I think that's my last slide.
Yes, ma'am. Thank you very much. As usual, just please submit your questions via the Q&A. We have a lot of questions coming in. So let's go ahead. Actually, really quickly, let's do the poll really quickly before we get deep into questions. And if we go a little over, people have to jump off. So I'm going to launch the poll really quickly. So if you can just take a moment to respond. So fall harvest, what are your thoughts on the fall harvest occurring the day after CHSD AQO day? Keep it the same. I'll get my data ready to go before AQO. Please move it 2 weeks later. I'm not able to get my data in and cleaned up prior to AQO and okay with getting my fall report later than normal. Please move it 1 week earlier. I'll have my data submitted and cleaned and ready to go by no later than the week before AQO, or it does not matter to me. I'm good with it either way. All right, just one more second. Looks like our votes are starting to slow down. All right. I'm going to go ahead and end the poll. All right, thank you, everyone. We'll take a look and review the responses. And then also Carol has also posted, if you know of anyone that's not on the webinar today, Carol has posted the poll on our Data Manager Facebook group. So if you could please, get in touch with anyone you know that's not on and just have them complete the poll on Facebook if they're a member of our Data Manager Facebook group. So looks like we've got, results are spread across. So we'll review and take it back to our surgeon leaders and we'll have an update. We'll provide an update on our next month's webinar. So thank you guys. All right, so let's get to our questions. We have a lot. So our first question, can you show the slide again? Hold on, with the table updates for 18 and 19. So here is the table 18 updated calculation. Will communication be sent out in regards to this, or should the data managers communicate this back to surgeons? And lastly, will we be notified when the updated tables are available? So we are asking data managers to communicate this update with your surgeons, with your group. We will. Again, like I said, these updates are scheduled to go out with the July 12 release, so it will be available to you all on the July 12th or first thing Monday morning, July 14th. There will be a notification posted within the IQVIA platform that the calculation has been updated and the updated tables have been released into the platform. And then also, since we do have a webinar literally Tuesday after the next week, I'll also, announce this on the July monthly webinar as well. So again, here's table 18 and table 19, the updated calculations. All right, next question. Best way to communicate the table 18-19 issues to the anesthesiologists. Thank you. Chas, Leslie, do you guys have any recommendations other than, unfortunately the 6.23 cases were not being included in those counts when intubate equals yes?
Yes, that's what I've done with my team, is just let it be known that this information will be updated, and then I will get them new tables that I put together for presentation once that has happened on July 12th.
Awesome, thank you. All right, next question. Does the overlap episode of care matter if the patient was discharged or not?
Yep, I could take that one. That's a great question, Jen. So yes, it matters. If your patient has not been discharged, then the episode of care has not ended anyway. So again, your episode of care is defined as admit date through database discharge date. So if your patient is still admitted, they don't have a database discharge date, and therefore it's just ongoing. Same as if they go to another hospital, whether they come back or not, you still don't have a database discharge date until they have gone home, expired, or met the criteria of being in a chronic care facility for 183 consecutive days post-op. So the overlapping episode of care rule only applies when your patient has gone home and has an end to the first episode of care.
Okay, thank you. Next question. Oh, Brooke pointed out for those, the webinar discussing episodes of care was February the 18th, and she put a link to that webinar in the Q&A. And I think we can also put that into the chat as well. So I'm going to just put that there. So thank you so much, Brooke. I appreciate it. Next from Becky, thank you for the changes over time tables. Can you also add when our local data will match the harvest data? Yeah.
Interesting question. So I don't know if we can add when your local data will match harvest data, because right now, currently, it is not required that you match it anyway. Like we're not requiring you to go back and match your primary procedure. You can leave it the same. These reports are simply telling you what will be analyzed as primary procedure.
Yeah.
But right now we have not had that. As we can see, thank you, Leanne, for putting the tables back up. There's still an overlapping year between the update to STAT 2020 scores and then the new primary procedure rules right now. So I don't know.
That might get a little complex. Yeah.
Yeah, I don't know. We can put that exact in there. For some sites, it might never match.
Yeah.
But hopefully we will have a long enough period where we do.
Yeah.
And that we don't make any more changes that will allow an even further extension of the time period of mismatch.
Becky, I see you have your hand raised. I unmuted you or allowed. I don't know if you have your question. If you go ahead, you should be able to.
Yeah. Do that. Sorry, but thank you for answering the question.
Oh no, oh good. Okay, perfect. All right. Next, I think the most I think for the most part, understand the new rules regarding overlapping episode of care and that only the first case will be analyzed. However, what happens with the complications on the second index operation? Are they attributed to the first index operation or only the mortality if the patient dies after the second index op?
Yeah, good question. So right now, there's been no change to how we collect data. There's still overlaps with your patient. If they have one index operation, they go home, they have a second index, new episode of care, new index operation. There's still overlap in how those complications and events are captured. There has not been a change yet to how those are collected or which events the complication events are attributed to. Right now, it's only the mortality.
All right, and Jen is piggybacking off the last question. What if the first operation is not an index op, however, there is complications afterward? When the patient has an index op with even more complications, historically, we only listed complications after the first reoperation, but how do we enter in this situation?
So complications which occur prior to an index operation won't be collected in postoperative events, but instead are preoperative factors to the index op. So again, no change has been made to how we collect the data. You'll still collect all of the data from for post-op, intra and post-operative events on the index operation. But Jen, if you have a specific case you're looking at and want to send us an FAQ, we can kind of dig into it further and parse that out for you.
Excellent. Thank you, Jen. Great question. Janet, when do you think these newer since 2014 will be added to the model? That's a great question.
Yeah, I don't think there's a date yet. I think it is on everyone's mind that we need to look at these and do some analysis to create an updated model, but I don't think that there's a timeline yet.
Yep. I saw Dr. Jacobs said, I saw you came off mute, or did you have anything to add on any model revision or?
No, I didn't need to come off mute. I'm just listening.
Oh, okay. Perfect, thank you. Yeah, so we have talked about it with, Dr. O'Brien, our CHSD workforce chair. So I think that is like Leslie and Chessie said, but it's on the list. So it's, something that's been brought up in surgeon leadership is discussing, and we'll share more as soon as we know more info. All right. And our next question from Marina, have many shunt reops. Am I to go back and change them now?
No. So when we make a clarification as spelled out multiple times in these webinars, as well as in the training manual, you don't need to go backwards and recode your data. You start from this date forward and recode or code your data as you move forward. So you do not need to go backwards at all. So for the shunt reops, if you have it coded differently, as long as you were following the rules of the training manual, you are fine.
Right. Next question from Amy. We really don't like leaving fields blank. It makes things confusing when cleaning data. For example, is data truly missing or purposely not entered? In the next version upgrade, can you consider adding options for not available or something of the likes? Absolutely.
Yes, we
Preach.
agree.
I hate it.
Yes. We love that idea. Absolutely.
We agree. Our next question from Becky. For the ASO case scenario, what if the patient was in a hybrid room and never left the OR? Would the coronary artery repair still be counted as a separate surgery?
No, it's an excellent question, Becky. So you're correct. If this patient had their arterial switch operation in a hybrid room and then had images that were obtained in that hybrid room, again, by definition, if the case ends when the patient leaves the operative setting, that wouldn't have happened if it were a hybrid room. So it would then not count as a separate surgery. And in that scenario, you would include the coronary artery repair as a procedure done during the arterial switch operation.
Great question, Becky.
Yes.
All right, for the return to the OR for the kinked coronary artery, what would you select as the reason for unplanned cardiac reop? Recurrent or residual lesion or other reasons, as this would not be for bleeding?
Absolutely. So I should have added this as the next question in the scenario, but it would be for recurrent or residual lesion because it's not for bleeding and it's not a mediastinal exploration for any other reason. You are correct.
Great question. How do you capture anesthesia data on these reops during one anesthesia episode? I would imagine that the patient would only have one induction time as they would be under anesthesia's care the whole time, but the second OR entry time would be after this time. Or is this a case of do the best you can with what you've got?
Yeah, I think like for right now, I think it is do the best you can with what you've got. If you have a patient scenario though, you are welcome to send it to the FAQ box and I can forward it over to anesthesia. Actually, I might be able to copy this one and just see what the anesthesia folks take would be on it if there's any guidance, but
Okay.
I have not seen this. Thank you.
Okay. You got the question, Leslie?
I think so. Yes.
Okay. And thanks for showing the slides, Leanne. You're very welcome. Can you show the slide prior to the two you pulled back up? It was the overview, not the calculations. Okie dokie. This one? So yeah, so the calculation updates are coming to tables 18 and 19, and it's just specifically just for extubated in the OR and re-intubated for respiratory failure. These are the only two calculations that are being updated for tables 18 and 19. All of the other calculations that are presented on those tables will not be updated. It's specifically just for extubated in the OR and re-intubated for respiratory failure. And of course, that'll impact the participant and the STS overalls. And it will be included with the IQVIA 12th update release. All right. And you're very welcome. Next. Is this the one, the table 18 and 19 you showed? Yeah, right before the calculation. So yeah, there you go. All right, Amy. And that, all right, before I don't see any other questions. So just really quickly, while we're waiting, next webinars, our next upcoming CHSD webinars, our next webinar is scheduled for July 15th. And Leslie will be doing a demo of the harvest tools, the missing variable report, harvest summary report, primary procedure mismatch. So just a review of the IQVIA tools and report. And it's going to be, very, we're going to get down to go back to the basics, I guess, kind of, Leslie. So it'd be a good review for anyone. So join us on our July 15 webinar. And then also I'll, have our updates related to the updated table calculations and things like that as well. And
Leanne,
then, yeah.
So sorry. I did say IQVIA report review. I think Chastity and I want to do the tables, the analyzed tables.
Oh, yes. Okay.
Correct.
Analysis review, not the
Not the
harvest deep dive.
harvest. Okay, good.
Yep.
All right. Oh, I was
Sorry.
reading. No, I was reading the little note in the slide. So sorry about that. Yep. So it'll be I give you a report review since our reports have just been released. Chas and Leslie will be going through understanding your report kind of basic interpretation. All right. Perfect. And again, our contact information, if you need to reach out to us here. All report related questions. You have questions about the numbers in your report. You have a question about why certain operations were not included in table 16, anything like that. Please reach out to tech support, STSDB_helpdesk@sts.org. Chas, Leslie, myself, we don't have access to your data. So we would not be able to tell you why specific cases were excluded from some of your tables. But if you have clinical related questions or things like that, please reach out to the FAQ mailbox. And but again, just all report related questions should go to our help desk team here. And if they can't answer it, they will forward along to the appropriate team members. All right. And I'm not seeing any additional questions come in. I don't see any hands raised, so I think we are good for the day. Thank you, everyone, for taking the time to answer the poll. Again, the same poll is out in our STS Data Manager Facebook group. So again, if you know of someone who is not on today's webinar, please have them go and complete the poll out on the webinar, out on the Facebook group. But again, thank you, Chastity and Leslie, for your phenomenal education. As always, we greatly appreciate you. And with that, I hope you guys have a great rest of your day, and we will see you all soon. See you next month.